Works. I also want to acknowledge our co-sponsors for this particular talk, the Division of Neonatology and the NICU at mHealth, University of Minnesota Masonic Children's Hospital, and the Division of Maternal Fetal Medicine in the med school here at the university. We're grateful for their partnership in bringing this program to you. So, without further ado, I'm going to introduce to you our speaker for today, who I have to say I am delighted to introduce to you. He is one of our own, an alum from our master's program in bioethics here at the University of Minnesota. His name is Chris Kalura. Dr. Kalura is an assistant professor of pediatrics at Mayo Clinic College of Medicine and Science. He earned his bachelor's degree in theology from St. Louis University. It was this course of study, specifically in morality and healthcare, that inspired his interest in bioethics. He received his medical degree from St. Louis University School of Medicine and trained in pediatric and adolescent medicine and neonatal perinatal medicine at Mayo Clinic in Rochester before completing a second fellowship in pediatric palliative medicine at Harvard. He joined the faculty at Mayo Clinic Children's Center in 2014 and currently serves as the medical director for the Level 4 Neonatal Intensive Care Unit. During his graduate medical training and his time as a junior faculty member, Dr. Kalura completed his Master of Arts in Bioethics degree from the Center for Bioethics here. He currently chairs the Mayo Clinic Pediatric Ethics Advisory Board. His research focuses on supportive care for children with complex chronic illnesses, with particular attention to shared decision-making in neonatal, perinatal medicine, and in the care of children with life-limiting and life-threatening illness. Please join me in welcoming him back to the University of Minnesota.
Thanks, Deb. Thank you so much. Can you hear me okay? Yeah? Okay, great. Well, it's certainly a pleasure to be here and see so many friendly faces that I learned so much from. I'll tell a quick story to kind of root us all into where I'm coming from with this topic. When I was an intern in pediatrics now over 10 years ago, I had not spent a lot of time in a neonatal ICU. I had kind of passed through in medical school as part of consulting services, but the medicine, the setting was quite foreign to me when I was a pediatric intern. And at that time, we took 30-hour call shifts, and every third night we were on, and so I was on with two other interns in the NICU. And kind of, by the book, then nights would come, and the 1 week in January, every night there was a baby born extremely premature at 23, 24 weeks. And 3 nights in a row that happened, and so each of us admitted one of those patients and followed those patients and cared for those patients with our attending neonatologist and tried to learn as much as we could. And then also kind of by the book, strangely so, based on all the population cohort studies that we look at, the statistics that we see kind of translated to those 3 patients. And one actually died shortly after admission to the NICU, had an overwhelming intracranial hemorrhage and very, very sick lungs. And one was able to move through the NICU course relatively smoothly. No NICU course is ever completely smooth. Was able to come off the ventilator and come off CPAP and feed and grow and go home from the hospital. And we'd see that baby in clinic, and she'd be doing quite well over the course of her early childhood. The patient that I followed was kind of caught in between. Had several very significant complications, also intracranial hemorrhage and multiple infections, very, very sick lung disease that would eventually require a tracheostomy and long-term mechanical ventilation. And it was by that I began to witness and see the impact of the constant decision-making that the family faced as they navigated this very, very complex route. And that's when I became very interested in these concepts regarding the limits of viability and specifically the decision-making that is involved and how they impact families, and really specifically how we can do that better. And so it's been a longstanding interest of mine, and this work is an ongoing kind of venture beyond just that clinical space for me. I don't have any disclosures, but I do have to be honest, I kind of toyed around with just filling the slide with a bunch of pharmaceutical interests just to see how that would fit with the ethics audience. But I wasn't quite that bold, so I don't have any financial interest to disclose. You can't really talk about the limits of viability without acknowledging this man. Dr. Bill Meadow was a neonatologist and ethicist at the University of Chicago. And I was fortunate enough to see him speak several times and spend a great deal of time with him in the literature. I did not know him personally. I did not work with him. But beyond a pioneer in neonatal, perinatal ethics, he's really a luminary. He died last month in Chicago. And so given the topic today, I wanted to make sure that we paid tribute to his incredible work in this field. So that's a bit of my story, but I also want to share kind of really a patient story. And this is a patient that's well known, actually well published, and is written on this topic. And so you can find this story anywhere. This is a patient named Kelly Benham, now Kelly Benham French, and she documented her journey with a baby born extremely premature at peri-viable gestation in the Tampa Bay Times, where she was a journalist and writer. And she was actually a finalist for the Pulitzer because of this work. And so Kelly and her husband, Tom, were pregnant, and like is oftentimes the case in a peri-viable gestation, she suddenly had significant complications. And she went to the hospital. She was bleeding. And the doctors were very, very worried about her, and that the complications were going to become life-threatening for her. Her husband was extremely scared, and soon things quieted down a little bit, and they began to think about what would happen if this baby was born at 23 weeks, which was her current state of pregnancy. And she talks about, in came a neonatologist who started to describe different statistics and outcomes, stood at the end of the bed kind of talking down to her, and realizing that, like most moms in this situation, it's not something that she'd ever thought about before. What would it be like to deliver a baby just barely halfway through pregnancy? And what would that look like for a baby born extremely preterm? And so she talks about her pregnancy, that, everything was perfect until it wasn't. And she shared this story not only in the Tampa Bay Times, but in a podcast called Radio Lab, which some of you probably have heard of and listened to. It's a kind of a news magazine podcast out of New York City. And this is an episode dating back several years now, but is really wonderful to listen to. And I just want to play a 2.5-minute clip because her words capture this so much better than mine.
And at 23 weeks and 4 days, the doctor tells her that there's nothing more they can do. The baby is going to come in a day, maybe 2.
The guy comes in, and he seems a little uncomfortable, like this was not pleasant for him. He said, your baby's probably coming in 24 to 48 hours, and we know how hard you work to have this baby, and we know how much you want this baby, and we assume that you want everything done. What does that mean? We had no idea. So we said, we're not sure if we do want everything done. Paint the picture for us, doctor. And he said, there's about a 53% chance that the baby will die no matter what we do.
53?
Yeah.
Whatever we do.
Whatever we do. There was a small chance that she could be fine.
What were those chances?
About 20. I felt like 20%, it's not an impossibility. It seems like a reasonable, it seems like worth a gamble until you really think about what the 80% means. I mean, she could be on a ventilator for the rest of her life. She could have a massive bleed in her brain, and it would eat holes in her brain and affect her ability to think or talk or walk. Pretty good chance she could be blind or deaf, and there was no way for the doctors to predict.
But what the doctors did know is that when the baby came into the world, it would need a ton of medical support. It may even need to be revived. And so the question for Tom and Kelly was, do they want the doctors to do that? Do they want them to pursue every measure possible, or no, and just let nature take its course?
And he said we should decide before the baby came, because once the baby came, if we saw the baby, it would be really hard to say no.
Yeah.
So if no was going to be the answer, we needed to just say that before the baby came.
That's the worst night ever. You're trying to make up your mind about what's right.
Like, would we be torturing this baby for nothing?
We didn't want her to be born and have a life that she would hate us for having.
So that's really what we're talking about today. And Kelly's words are so powerful because she's experienced this as a mom and Tom as a dad. And so everything that she's written on this topic has been incredibly invaluable to other patients and certainly providers, because before that we have expert opinion, and they're great experts. They're wonderful people who I know in the field of neonatology, and they have written incredible articles to help guide us in how we have these conversations and what's important. But we've started thinking as a field of how can we move past expert opinion and really understand what this decision making looks like, and what this decision making looks like from a patient's perspective, so that we can think about how we can do it better. This is actually Kelly Benham French and her husband Tom and their daughter Juniper, who was early in her NICU course. And this is the book that Kelly wrote that I'd strongly recommend. I had a chance to give a talk with Kelly at ASBH a few years ago, and she's just an incredible resource. She's written academic articles as well about this experience. And so I would certainly encourage anyone who's interested in this topic to think about this. So hopefully that kind of frames what we're going to talk about here over the next hour. And then as we move into the qualitative work that we've started to undertake and analyze within my research group. But I want to take a big step back and kind of hit the reset button a little bit, just to frame what does peri-viable delivery look like. So cue the big baby here. So there's 4 million births in the United States every year. And of those, over 500,000, 550,000 roughly, are premature, born less than 37 weeks gestation. But we're talking about babies that are born at 22, 23, 24 weeks. So sometimes when I sit down with families and I say, have you ever known a family friend to have a child in the NICU? And they'll say, oh yeah, and my neighbor had a baby born very premature. And this might be helpful as we kind of frame the context. And I'll say, well, do you know how early that baby was? 35 weeks, right? And so prematurity is a big thing, and we think a lot about babies that are born 35 weeks, but most of those babies might spend a short time in a special care nursery or the newborn nursery. But we're really thinking about a completely different population, a completely different set of risks that's actually quite rare, which is good, and it's getting better. About 35,000 babies are born extremely premature, and what that means is less than 28 weeks of gestation. And though they account for just a sliver of the overall live births of our 4 million babies in this country, they actually account for most of the infant mortality, babies that die within the first year of life. And so you can see 45% proportional infant mortality is for extremely preterm babies. So it's a big deal, and we are working to get better. Our outcomes are slightly improving over recent years, and probably the most important thing is the prevention of premature birth in the first place. So this is what we're talking about. Extremely low birth weight babies are less than 1,000 grams, which is a little over 2 pounds, and really extremely premature, less than 28 weeks. But we're focused on this gray zone of viability, 22, 23, 24 weeks of gestation when babies are about a pound, a little bit more than a pound. And it's called the gray zone of viability because, as you would imagine, with each passing week of pregnancy, the outcomes get dramatically better. So a baby born at 22 weeks, when you look at these big, large population-based cohorts, has a roughly 95% chance of not making it out of the NICU. That's really high mortality. And it drops a bit at 23 weeks, and then it's about 50% at 24 weeks, and then you can see beyond that, it drops considerably. So a baby at 28 weeks has almost an inverse chance of making it out, even though it's only been 6 weeks of pregnancy. And what about making it out without experiencing severe morbidity? So severe complications like very, very severe long-standing lung disease or severe infections like sepsis or necrotizing enterocolitis, which is a major complication with the intestines. At 22 weeks, again, looking at these large population-based studies, no babies in that study made it out of the NICU without experiencing a major complication like that. At 23 and 24 weeks, only about 1 in 10 could make it through without having one of those major complications, but it gets better really, really quickly with each passing week of pregnancy. So again, that's why we think about that gray zone of viability. So you might say, okay, that's great. You're talking about survival. You're talking about complications. But what does life really look like for these kids over time? What does it look like when they go to school, when they go to grade school? And so this is a bit dated data, but to be honest, it hasn't changed a whole lot. This is looking at extremely low birth weight babies at 6 years when they go off to kindergarten, and how do they compare to their school-age peers. It's really, really hard because it's all over the place. We see this every single day in the NICU, and when we see our babies, when they come back to the NICU and we see them at reunion picnics, we see some of them have very severe disability, and about a quarter of them will, in which they're in wheelchairs, they have very severe cerebral palsy, they're dependent on their caregivers and probably will be for the rest of their life. They may be dependent on machines to help them breathe and help them eat. Where others, 20%, 1 in 5, will actually be doing just as well as their school-age peers that were never born premature. And then the others fall in between, with maybe even just very mild disability, which may be a learning disorder or visual impairment. And so this makes it very, very hard. Whenever I give a talk on viability, someone always asks, well, what's going to be the next line? You guys say 22 weeks now, but I remember when it was 28 weeks 25 years ago, and when am I going to hear that it's 18 weeks? Well, as long as we use the lungs for ventilating babies and using end airways for gas exchange, there is actually a physiologic edge that we've reached in which babies' lungs are actively developing at 22, 23, 24 weeks, and just then forming end airways that can achieve gas exchange. So as long as we're using the lungs for gas exchange, this is the paradigm that we're thinking of, but we're not just using the lungs anymore, and there's development of an artificial placenta that may be a conversation that we're having, and certainly a conversation that ethics is having concurrently, but I'm not talking about the artificial placenta today. I've drawn the line. We're not going there. And it's not just about gestational age. And I see this in the NICU all the time. A mom's threatening delivery. She delivers at 22 weeks, and everyone is very, very anxious. There's a 22-week baby coming. There are 22-weekers coming. And the baby's going to be very, very, very sick. And maybe the next night, a 25-week baby's coming, and no one's quite too worried about it. But it's not just gestational age. We get too caught up in the weeks too many times. Girls do better than boys. That is statistically proven. We see that every day in the NICU. We don't know exactly why, but that is true. Babies whose moms got steroid shots before they were born to help mature the lungs and decrease the risk of bleeding in the brain do better. Singleton babies versus twin births or triplet births do better, and birth weight plays a major role. And so this kind of illustrates it. There's big calculators based on all these population-based statistics. And if you take a baby that's 25 weeks that's growth restricted, that's a boy and is a twin and mom didn't get steroids, they have about a 20% chance of survival. And you take that 22-week baby that everyone's very anxious about, and some people may be very accusatory of why are you resuscitating 22-week babies? But is a good-sized baby, who's a girl, is a singleton and mom got steroids, and they actually have a higher chance of survival. It's not just about the weeks. It's really important to understand. I'm giving a talk to the OB residents in a few weeks, and that's one of the things I will definitely hammer because there's so much emphasis on weeks. And so we've started to kind of understand what does outcomes really look like, because this is kind of general data that we see, and I showed this from a different cohorts, but 22 weeks, when you think about all babies, at 22 weeks, 5% of those babies will survive. That's looking at all babies, including those whose parents have made thoughtful, loving decisions not to proceed with resuscitation in the delivery room, in which they receive comfort measures only. We start asking, well, what does it look like for babies that do get intensive care? Because some hospitals will say, we don't resuscitate 22-week babies because they don't survive. It's a bit of a self-fulfilling prophecy, right? If you don't resuscitate 22-week babies, they certainly won't survive. You start looking at the babies that got, in this study from New England Journal several years ago, active treatment, which means that they likely were intubated and received mechanical ventilation, central lines, surfactant, et cetera, then their survival is certainly much higher than what can be quoted. And it's still not good. Don't get me wrong. These are not good numbers. But we need to really be accurate in what we're talking about. When we're talking about 24, 25 weekers, they're very, very close because almost all those babies are resuscitated regardless. We look at this kind of paradigm across the country, and this map represents neonatal research network centers, which are very large centers. They care for a large number of babies, provide very good care. We see a huge range of centers that will provide resuscitation at 22 weeks versus those that won't. This is important because those that do it a lot, their outcomes are actually much better than those that don't do it a lot. And so as we think about this with a mom that's come in the middle of the night in this kind of sudden emergency, and we sit down and we really start to think about what this looks like, this all plays a role. And as you can tell, there's a great deal of uncertainty, there's variation. And at the end of the day, we have national guidelines that tell us 22 weeks is the lower limit of viability. And the American Academy of Pediatrics and American College of Obstetrics and Society of Maternal Fetal Medicine say that this consultation is so important, and it needs to be individualized, and it needs to be family-centered, and it needs to really think about what makes the most sense for each individual family at 22 to 24 weeks. That the decisions towards the provision of resuscitation versus withholding resuscitation need to be individualized family to family where things currently stand in the United States. But it doesn't tell us how to have the conversations or what training to provide or how well we're doing. We see other research that tells us that the prognosis is multifactorial, like I was talking about, and that counseling practices are really variable all over the place. The quality, the accuracy of consultation, there may even be unconscious bias that I'll talk about in a second. And that this study showed actual survival. And then it asked obstetricians and neonatologists and nurse practitioners, and they actually underestimated survival, right? And sometimes up to 20% underestimated it. Why is that? Is there a bias? This is a study that was published over 10 years ago. It's a tremendous study in showing unconscious bias, potential unconscious bias in this population. This was by Annie Janvier and Keith Barrington, who are neonatologists and also parents of a 24-week baby in Montreal. And they asked graduate students, probably similar to some of you, in bioethics and medicine and law, and they gave them scenarios for these different patients at different ages. And they said that, okay, for a baby born at 24 weeks, and then a baby born at term and a baby at 2 months old, if you were to resuscitate that baby, they would have a 50% chance of survival. They would have a 50% chance of a normal outcome. They would have a 25% chance of a new disability. Is it in the best interest to resuscitate that baby? And then they asked about a 35-year-old, and they said it's no longer 50, 50, 25. It's a 5% chance of survival, 0% chance of a normal outcome, and 100% chance of a new disability. At 24 weeks, 79% of that cohort who responded said it was in the best interest to resuscitate. At term, it was over 90%, and for the 2-month-old, it was about 100%. The only variable that was different was the age. The 35-year-old who had worse outcomes still had a higher proportion of respondents saying it was in the best interest to resuscitate versus the 24-weeker, and the only patient that was lower was the 80-year-old, which talks about potential bias towards the extremes of life, and why is that the case? These are things that we have to think about. So when we study this, parents say that, moms say they're generally satisfied with these consults. And I certainly hear that from moms. That, yeah, we got good information, we thought we could make good decisions, but that type of information doesn't mean that we're actually doing it well. And when we look at satisfaction, it's really a poor predictor of actually how much is understood. And that parents that were highly satisfied, they may not have had a very good understanding of what things looked like. Because families don't know what they don't know at that point, right? If you talk to them on their day leaving the NICU, they'll have lots of thoughts for you, because they're incredibly educated about what this all looks like now. Not a surprise, the moms desire individualized, realistic information despite gravity of prognosis. Even if the news is bad, they still want to hear it, and they want to hear it in an individualized way. They want the truth, right? But they also want you to hold hope with them. They want to maintain consistency, because if they're hearing something different from the obstetrician, the neonatologist, the fellow, the resident, the nurses, you can imagine what that does to their anxiety, their trust in their team, their confidence. right? And these are issues that we have across all of medicine, not just in this setting. And despite all the statistics and the morbidities and everything else that we talk about with families, at the end of the day, religion, spirituality, and hope drives a lot of decision making. And guess what the things are that we talk about the least or not at all, right? This is what our research shows us. We're not trained to explore spirituality with families. It brings me back to a communication seminar that I did when I was a palliative medicine fellow in Boston. And we sat around this big table, we talked about all these strategies, and there was a mom there. And she was a parent representative, and she kept raising her hand and saying, well, you know, in your training, I'm sure you're taught this, and then in your training, when you sit down with a mom, I'm sure you're taught this. And finally, someone was brave enough, one of the trainees was brave enough to say, we actually don't get any training for this at all. Which is probably very surprising to patients. That the one thing that we do most of all, and probably has the biggest impact on outcomes, is communication. And there's very little to no training. If there is training, it's really based on a modeling method. And that's what we see. And neonatology specific fellows have said that they were least prepared to have conversations about end of life. So it got me wondering. I've wondered about this for a long time, and kind of take all the stacks of really reputable authors who I have a tremendous amount of respect for. And I said, you know what, I'm just going to kind of clear it off the table. We're going to try to understand what's happening within these consults. And we're going to try to build this from the ground up in a very kind of organic way. And hopefully this will lead to lots of future mixed methods and quantitative studies that can help us to really understand what is the purpose of this consult. How can we reach decisions effectively? What are the needs from the parents, not the doctors? And so our aims were to quantify the content that we talked about, what specifically was talked about. And the most important thing was to gain an understanding of the thematic strategies used by the neonatologists with moms, and then analyze that shared decision making. We used a real-time audio recording of prenatal consultation. So mom would come into the hospital, she's threatening preterm delivery, extremely preterm delivery, to which the obstetricians felt that they needed to have neonatology come talk with them, and then we asked if we could record that conversation. It went through an informed consent process. Neonatologists and neonatal perinatal medicine fellows were involved in the study, so we consented them. And then moms were consented, and her partner or any family that was present for the consult also consented. These are English-speaking moms that were greater than 18 years of age. They were admitted for these threatened periviable delivery, and then their consults were really indicated whether decision-making was necessary to provide or withhold resuscitation at time of birth, which is really important for obstetricians because they need to know if they should give steroids to help the baby and magnesium to protect the baby's brain, or if that's something that they should wait until they reach a gestational age or a point in which decision-making changes. And then that capacity was determined by the obstetric team, and this was IRB approved. So over 18 months, we enrolled 25 moms out of 28, which I think was very impressive to me, because a lot of people have said, oh no, our institution wouldn't let this happen. This is such a highly emotional, highly stressful moment. No moms would enroll, staff wouldn't support it. So I said, well, let's give it a shot, knowing that we kind of really need that thematic saturation in qualitative medicine with numbers into the 20s. And I'm not a qualitative researcher, so I rely on a sociologist who's a wonderful qualitative researcher to really guide a lot of this. And we said, let's go for it. And we enrolled almost all moms. And then out of the 25 consults, there were 22 in which other people were present, partner or family. Certainly moms who were instructed that at any point you can ask for the recorders to be stopped. You can withdraw from the study. That didn't happen. 8 neonatologists and 2 fellows were involved as well. The audio was then de-identified and transcribed by qualitative transcriptionists, so then we reviewed the transcripts. We also conducted follow-up interviews with the neonatologists. We conducted following the consult, which is a mean of about 10 days since the consult. It was important that we tried to get those providers shortly after the consult, so there wasn't a lot of recall bias with what was happening within the consult. And then the mom and the family, we decided to follow up with them and do interviews after delivery, which was about 19 days after delivery, mean days after delivery. we did interviews, and 19 of 25 completed those. There were some moms that delivered at other centers, then we didn't follow up, that we lost the follow-up, and I think 3 refused interviews after delivery, because as you can imagine, it's an extremely stressful time, especially if your baby's very, very sick in the NICU. Sitting down with an interviewer is probably the last thing you want to do. Maternal median age was 28 years, about 3/4 were married, relatively homogeneous white population for moms, but we did have some diversity. The neonatologists, I work with a very homogeneous group in Rochester. Unfortunately, we can do better there, and 20% were female. So this is a big table of all of our consults that we enrolled in our study. Our mean age at time of consult was 23 weeks and 0/7 days. They range from 21 and 2 to 25 and 1. We typically think about 22 to 24 weeks as the gray zone of viability. Any baby that's born beyond that will trial resuscitation without decision making involved. But there was one baby at 25 and 1 because the baby was severely growth restricted and had placental insufficiency, and so the likelihood of death was very, very high. So decision making was indicated at that point. The most common indication for that consult was PPROM, or premature prolonged rupture of membranes. This is really, really tricky because for about half of moms that rupture early or their water breaks early, they'll deliver within roughly 9 days. That's kind of what the studies show. But half won't, and they'll go longer. And so if you're sitting down with a mom who has rupture at 22 weeks, you're talking about really, really scary stuff. It's really, really highly emotional when you think about decision making. And we don't know really kind of at that point if that's going to be a mom that may go from 23 and 6 and then doesn't deliver till 32 and 4. That's a great scenario, right? And so sometimes you hope that we're going to talk about these things because it's really important to have a plan and be prepared. But I'm actually not hoping to see you for several weeks, right? The most important place for the baby to be is with you and not with us. And then you have others that deliver kind of still peri-viable, and others in the yellow that are still extremely premature. So we have a few that move beyond that kind of extremely premature mark that ruptured quite early. And then thinking about decisions, so not all of these consults actually reached a decision. Some of these decisions were then kind of left hanging. Maybe the family wasn't ready, the physician didn't feel like it was absolutely necessary to reach a decision in that moment. It was always a bit unsettling because if you're kind of coming on for the night and say, oh, you had this conversation, what's the plan? And say, like, oh, we didn't really reach a plan. So like, okay, well, if they call me at 2 in the morning, what are we doing? So we have to kind of keep visiting, keep talking. And then at least at the time of the consult, 3 moms made a decision for comfort measures only for the baby. That doesn't mean they actually received comfort measures. They may have gone longer and been resuscitated at a later date. But at the time of the consult, that was the decision that was made. So just to spend a couple times on kind of boring methodology, but it is important, especially for researchers in the room. Real-time audio recording, it's wonderful. It completely eliminates recall bias. You have the sample of what actually happened within the consult, right? And we've spent, hours together kind of analyzing these transcripts, and it's really rich data, and I feel like we've done really wonderful analysis, and I feel like we've only started to get past the surface level. There's a lot of studies, there's some studies that look at kind of high fidelity simulation with these consults, but this is actual experience versus simulation. The one problem is this calibration bias, right? As a neonatologist, I'm going in the room and I know that I'm going to be recorded and talking to a family, and they may feel the same way. And at my institution, not only do they know that they're being recorded, but they actually know that their partner or me is going to be looking at these transcripts. And they're de-identified, but I talk to these people every day. I know exactly how they communicate. So I know who's who in those transcripts. And I participated in this study as well, and I felt that same way, even though I didn't have other neonatologists listening to me. I still had our research team looking at these transcripts and then talking about every little word that I uttered, and sometimes was quite nervously because I knew that was happening. So real-time audio recording is not without some fault. The study team was 2 medical sociologists, both had expertise in perinatal medicine, and one with expertise in conversation analysis, and then 3 physicians, 2 neonatologists, one was a fellow, and a palliative medicine attending. We did deductive content analysis between the 3 physicians to determine actually the information delivery that was being provided in the consults, what the typical medical information was, and then looked at that with consensus review so that we would agree that that truly was being delivered. And then really the kind of heart of the study was the inductive applied thematic analysis, in which we did descriptive and exploratory interpretive knowledge, which basically means that you get together, you go through the transcripts, and you start really kind of organically building these themes that you start seeing repeatedly. And I'll talk about them. I'll do a deep dive on a couple of them with you today. This is the study team. Catherine Carroll and Karen Chapey are both wonderful medical sociologists. Catherine actually moved back to Australia, where she was originally from. So we've conducted video consults with her, and done all of our research meetings with her via video, which is 5 p.m. my time and 7 a.m. her time, so it requires a little bit of coordination. Megan Thorvaldsen is a palliative medicine physician, and Bethany Kamick's a fellow for us. And so what we did was we basically met, we reviewed 5 transcripts, we started to identify early themes, and then Dr. Carroll used those themes through our research meetings to kind of guide an ever-changing definition of kind of what those emergent themes were, and started creating a code book. Well, again, for those of you who have done qualitative research, you know this process. This code book ends up being several hundred pages with all of these codes pulled from these transcripts. These consults are roughly about an hour long, and so some of them are very, very rich consultation that happens. And then we would meet together and go through batches of 2 to 5 at a time, review all the codes that Catherine had applied systematically throughout the consults, and to make sure that we all agreed on them, and to further refine what was happening. A very, very time-consuming process, and that I think to do qualitative research, you really have to be invested. You really have to believe in what you're doing, because it is a tremendous amount of kind of really rich conversation and analysis that's happening. These are the themes, the 5 major themes that we are at this point. One is one of authoritative, where the emphasis in what's happening within the consult is really what the medical team is going to do. We call this kind of, our working theme was we doctors, because we see neonatologists talking about, we will do this, and we will do this, we will intubate, we will put on a mechanical ventilator, we will breathe for the baby. And that can be really at a reduction of what the parental role is. We see a lot of post-NICU studies. We see a lot of post-traumatic stress disorder for moms specifically, a lot of depression for moms and dads. And you do wonder, as this has been kind of played out in the literature, about the marginalization that families experience in an ICU setting, and how that informs those later outcomes. The second theme was one of personal agency, which we built through a theoretical framework, but really describes where the baby is attributed the ability to communicate, to act in the world, to have decision-making, granted some degree of subjectivity. I'm going to take a deeper dive on this theme of personal agency within our work with you today. The other one that I'm going to really look at closely with you is that of uncertainty. That's fairly self-explanatory, medical uncertainty, but this medical uncertainty was pervasive throughout our consults. And extremely interesting to see how it's navigated by physicians specifically. Alignment, another theme, is any kind of portion of that consult that in which the physician is trying to build a relationship with the family, and vice versa, where there's kind of trust being laid down, or a partnership, building goals of care through asking about what the family is hoping for, what they're worried about, what their values are, what their preferences are, what their experiential context is. Sometimes it can be meeting emotion with empathy. Sometimes it can be small talk. Sometimes it can be storytelling. A lot of alignment codes. And then kind of decision making, and that moment where there's decision making that's reached. And what do we see in those moments? So looking at the content analysis, which quite frankly, is kind of the boring part of this study. What do we talk about when we talk about complications? Well, we almost always talk about respiratory distress syndrome. These babies are born extremely premature. We know they're going to have surfactant deficiency as extremely preterm babies and RDS. And that's almost talked about in every consult. Bronchopulmonary dysplasia is chronic lung disease for the baby. About half of those consults, we'll talk about that. Interventricular hemorrhage is a very, very severe complication that happens with bleeding in the brain, and almost all the consults talk about that. Retinopathy of prematurity is a significant complications with the eyes later on in the baby's NICU course, infection of the bloodstream or sepsis about 2/3 of the time. Right? And so if you kind of look at some of these expert guidelines, some of them actually will give you a grid with checkboxes. That these are all the things you should talk about: RDS and BPD and IVH and PVL, and make sure you hit about all these things and talk about all the statistics. These are publications that have been published in major pediatric journals, and I would imagine inform the way a lot of neonatologists talk about these things. And Kelly French talks about that's how she experienced it initially, before that nurse practitioner came in and started talking about stories about patients. The neonatologist came in, he was uncomfortable, he was standing there, and he just kind of went through the list. And we saw that in several consults. The long-term outcomes, they are discussed quite frequently. Intellectual disabilities, cerebral palsy. And then the concept of, are comfort measures discussed? There's decision-making that's discussed regarding whether we should proceed with resuscitation or withhold and those intensive measures at the natural end of the baby's life. Are comfort measures really talked about? If it's an equally supported decision, do we talk about those comfort measures? And to some degree, this captures that, at least to some degree, they are explicitly discussed. To what degree, we don't know. Actually, Dr. Carroll is doing a manuscript and taking a deeper dive on looking at that balance. I wanted to try to capture a way to kind of show what these consults look like. What's the anatomy of the consult? And so I came up with this, what we kind of described as the hungry little caterpillar look to describe these. I used green, which looked more like the hungry little caterpillar, but I thought that this was at least a way to show what this interplay, what this kind of dance that happens within these consults looks like. And so yellow is, information delivery. So at the start of a consult, that might be neonatologist coming in and orienting the patient or the family to what a neonatologist is, what the service is, why they're there, what's the team look like, what's the delivery room look like, what's the NICU look like. And then there may be some small talk, relationship building. In this consult, there was an introduction of decision-making fairly early in the course. Again, that was kind of followed by alternating information delivery and relationship building, more talk about that decision that we are working together to reach. Kind of goes back and forth. And so this is kind of heavy with all phases, right? That's contrasted against a consult that may look like this, where right off the bat, there's a big chunk of information delivery, some degree of relationship building, but then there's not a lot of relationship building until the end, and these huge swaths of information delivery. Kind of what I was describing. And in a transcript form, you just see pages of a neonatologist talking and delivering lots of information. And you might see families saying, and the qualitative transcriptions capture that. Or there may be big swaths of information delivery, and then do you have any questions? No questions. When I teach communication, I always tell people in the ICU, if you want to move quickly from bedside to bedside, ask if they have questions. Because there will never be questions, right? You have to probe and ask, what are you thinking? What can we talk about, right? I can see you're upset. I can see you're worried. Then we'll get to what we need to talk about. But asking in a consult, what questions do you have after 10 minutes of information delivery? It's kind of the way I feel when I go sit with my accountant and he goes over my taxes and says, what questions do you have? And I say, none. I totally understand everything you're telling me. So this is more kind of a classic consult where you have all this information and then at the end of the decision and then a little bit of relationship building. And then we also have consults where it's like a lot of relationship building. And sometimes you read this and you're like, wow, this is just like all small talk and all storytelling. And they're not really getting at anything. But it can be very, very effective. And what we don't know is really how effective this is. Until we do a deeper dive on some of those follow-up interviews and even then it's kind of limited. It's really hard to say whether these are effective or not. We can just say kind of what is happening within this space. So our first major theme is uncertainty. And like I said, it was pervasive throughout our all the consults. It's a predominant theme in our analysis. Structurally, it was throughout the continuum of the consultations. And as you would imagine, uncertainty is especially present in the moments of decision making. And so I want to talk about uncertainty for a minute, because I've learned a great deal about uncertainty. We think about uncertainty a lot in palliative care, but I've learned a great deal about uncertainty kind of studying this. So Renee Fox wrote a book a long time ago called Evolution of Medical Uncertainty. It's very, very applicable today. And she really describes that there's this ongoing awareness and unease in medicine about uncertainty, and kind of a long history that we have this need to reduce uncertainty and be able to meet it with describing exactly what's going to happen for a patient. But what's so fascinating is, this is just to say that we're less and less tolerant of uncertainty. And the more we know, the more advances we have, the less that we're comfortable with not knowing, right? But actually the nature of scientific discovery is that as we lay uncertainty to rest, we find new uncertainty arises in its place, right? In neonatology, we found a way through surfactant to go lower and save more babies. But we have so many more uncertainties that came because of that. The artificial placenta may push that line of viability even lower, but I know there'll be so many more uncertainties when that comes. That's just the nature of the beast. That's the nature of scientific discovery. And that's not necessarily the problem. Uncertainty is not the problem. It's really our ability to remain aware of that uncertainty and actually be comfortable with it. And so we may deny that there's uncertainty so that we can take action. Like there can't be any uncertainty in order to make a decision. But when you live in spaces of uncertainty, and neonatology is one of those places, and palliative care is one of those places, you live in a lot of gray, and bioethics is one of those places, right? There's a lot of gray. Then we start becoming a lot more comfortable with uncertainty. And you actually know that if you can hold uncertainty and acknowledge it and name it and talk about it, it can really build a strong relationship, and it can really equalize this power dynamic that exists between a physician and a patient or a family. And we're going to hold uncertainty together, and now we can all make shared decisions as equal stakeholders in really rooting out what your goals and values are to think about a recommendation towards what is important, right? And so it can be a tool in that relationship building. I want to talk for a second about risk and uncertainty, because I think they're oftentimes thought of as the same. And so risk is really the probability that an event will occur. And oftentimes in medicine, we think about it, the probability that a negative outcome will occur or a complication will occur. Whereas uncertainty is really just this idea that we don't have a lot of information about risks or benefits or what the future of the individual is. We may have some, but we still lack clarity. And it's this much broader term. So when I talk to a family about the risk that their extremely preterm baby is going to have respiratory distress syndrome, I can say it's almost 100%, right? But if I talk to a family about what the likelihood is of survival or intraventricular hemorrhage or long-term lung disease or cerebral palsy, then those things are dependent on so many things that I can extrapolate population-based cohort statistics to give some degree of likelihood, but I'm not necessarily giving an absolute probability of the risk happening to this patient who I've never met and never laid hands on, who's never been born yet, right? And that's really difficult to navigate within a conversation, especially when it's highly emotional, everyone is stressed, it's 2 o'clock in the morning. And we see this is a line from our study. One of the neonatologists said, if there was one right answer, we'd tell you which one to do, and that's what we would always offer, right? So acknowledging and at least holding some degree of uncertainty. And I think the one thing is, again, confusing risk for uncertainty and physicians kind of faltering in thinking that everything needs to be absolute. And acknowledging that we don't have to let uncertainty paralyze us, that even in the face of uncertainty, we can still make shared decisions together. So let's talk about the uncertainties we saw. Actually look at this data. So we saw uncertainties around timing of delivery. This is really, really common, right? And these kind of go in order of more impactful. So that mom who's ruptured early, we don't know exactly when that baby's going to be born. We saw tons of examples of this. We can't predict the future. We don't know exactly when this baby's going to come. The date and time, the gestational age at time of delivery. So an example of that would be, perhaps the most important thing I can tell you is we just don't know when your baby is going to be born. It may not be for a long time yet, and that's great if that's the way it works out, right? So it's fairly simple uncertainty that we see and how the physician responds to that. Other one is, the big one is the NICU course, being able to kind of predict what happens to the baby over time. The infant survival, I would say the chance of survival for him would probably be somewhere in the 50 to 60% range, but you don't really know if your baby can survive unless we actually try. So how do we navigate and meet that uncertainty of infant survival? Short-term outcomes, long-term outcomes, and that's where things become hard, because we have babies that survive the NICU and have severe and sometimes even profound disability, and we have babies that survive and go home from the NICU that don't. Postnatal diagnoses, how well can we use ultrasound to diagnose intraventricular hemorrhage, and these types of uncertainties come out in these consults. Length of stay, for some babies they go home close to their due date, for some babies they may be in the hospital for a year. Individual characteristics of the physician, who am I, why am I here, who makes the decisions around obstetrics and neonatology, the uncertainty around who's going to be there at the time of birth, the individual characteristics of the parents, what is their context, what is their experience, what's their understanding, and then of the baby. There's a lot of variables. Steroid status. Baby boys have worse outcomes than baby girls. The actual size when born. Those are the things that kind of help narrow it down, right? So kind of holding some degree of uncertainty with the family. And then kind of ultimately is the consequences of decision making and how we meet uncertainty. So the moral consequences, and we see this from families. Mom says, I don't want unrealistic expectations. And the dad says, if there's a chance, some chance of having a kid that has a good quality of life, I would want to. I guess it's hard to have it both ways. But you wouldn't want to play what if your whole life. And so we see a lot of that as kind of protecting against regret. His mom says specifically, I have to make peace with the risk of regret. A really powerful statement. Logistical uncertainties. We have families that may not have secure housing day to day, may not have secure employment, may not know what this is going to look like with their other children's needs. A lot of financial uncertainties that we see in our transcripts. Just we'll have you talk to a social worker, right? So a lot of uncertainty around logistics that we're not prepared for, we're not ready to engage with. And then that external perception of the decision, this is a fairly powerful statement which captures this idea, right? Well, what are people going to think about me if I make this decision or that decision? And this mom says, are we being those, like, do you guys go back to your back room and be like, God, those people are so dumb. What are they doing? Like, if only they knew, they could just make better decisions and, let this baby go, right? Like that worry, that uncertainty about what the perceptions are. And so then what was really fascinating is how do we as doctors respond to this uncertainty? And there's many ways. One, a lot of times we provide lots of information, even if that information doesn't really meet the question. There may be a question about outcomes, and we can just talk in our language and medical jargon, and we can spew outcomes and statistics all day long, right? Because we're comfortable doing that. So large sections of information usually provided as a monologue. Or there could be big stories, right? And you saw this from the more senior physicians. Like, this is how things have changed over time. This is where we are now. Or families, maybe, I don't necessarily want to know about the 90s. I want to know where we're at now. But that's how we kind of answer this uncertainty, more information. And sometimes you saw the more information that was provided, the more questions there were, the more uncertainty there was. So answering uncertainty with information may actually potentiate more uncertainty. The most cited method for gaining certainty is the passage of time, or key moments. Once your baby is born, we see what the first days look like. We see what that head ultrasound looks like. We see if we can get them off the ventilator in the first few weeks. Actually, specific moments, right? And so you can kind of think about decision making towards great deal of uncertainty. They keep telling me that to answer that uncertainty, there's moments that will tell us, may move that decision towards a trial of resuscitation. Responding to just acknowledging that there are limits of medicine. Orient the family to the scope of what is and what's not known about peri-viability. Acknowledge and accept, right? Just what we kind of talked about already, like the importance of naming uncertainty, meeting that as a relationship building with families. I mean, that we kind of hold this together, and sometimes we have to reaffirm that we need to make a decision despite that uncertainty. Holding hope. And actually, uncertainty was used several times to hold hope with families, and specifically, usually after talking about really bad outcomes or really bad news. We're talking about that the likelihood is that your child will die. But we don't know for sure, and in fact, there's some uncertainty towards that, right? So uncertainty can be used as a tool to hold that hope, which is very important for families, and you actually saw families use that as well. But you don't know for sure, right? Tell me about the last baby at this gestation and what happened. And then responding to uncertainty and using it as a moment to build a relationship. And so there's opportunities to say that we don't know, but I can promise you I will be as truthful as possible when we have a better idea. And we'll continue to reassess, and there's lots of language about a partnership that we'll continue to engage in over time with families. So these are some examples. So this is one about statistics, is if you tried to save the life of 100 babies who were born in this exact condition that your son is in, 25 weeks, 400 grams, with concerning patterns on the way the baby is getting nutrients and blood flow now, the chance of survival would be 50 to 60%. So of the 100 babies that you did everything you could, 50 to 60% of those 100 babies would survive. Now, we'll say optimistically 60 babies who survived. Your question then is how many of those will go on to have long-term problems like cerebral palsy and issues with learning and keeping up with their classmates? I would say 30 to 50% of those babies who did survive would have long-term issues with learning issues or problems with cerebral palsy. There's storytelling. I'm not going to read this, but again, it's kind of about a more senior physician framing how things have changed over time. There's limits of medicine. We don't have any good way of predicting when or how long you're going to be pregnant. I certainly don't know that. And you know, even if I did know, okay, this is going to be the day, there's no way I could tell you how things are going to exactly turn out in terms of survival. There's holding hope. So it's hard to add any degree of certainty because the fact is there's reason to worry, and that's kind of the doom and gloom part of the conversation. And then there's reason to be hopeful too. I have absolutely cared for babies at 23 weeks that have had long intensive care courses that have gone home, and they come back and visited me years later, and they're very, very well and have very good quality of life, and their parents are very, very happy. So giving a lot of doom and gloom information, then holding some uncertainty and telling stories about how it's possible that their child can survive. Using uncertainty in relationship building. I just want to jump into personal agency because I found this probably the most fascinating thing that we discovered. So this is a major theme that I don't want to confuse it with personhood. Personhood, philosophical and legal definitions of citizenship and equality and liberty and what it means to be human. Personal agency is, what we're talking about here is basically describing the ability of the baby to communicate, to engage in the world, to actually help make decisions. That's a bit kind of counterfactual to what is developmentally or physiologically possible, and how we think about these things. And so when parents talk about this, when they talk about their baby being strong and active and being able to engage and declare, then there may be a great component of kind of relational autonomy. And what relational autonomy is, it kind of moves away from this individualistic autonomy concept in which rational thought and reasoning governs over emotion, right? Because very few complex decisions are actually made with completely rational decision making. And we see this battle of the head versus the heart, and this is ethics of care built out of feminist ethics in which relational autonomy really captures this. And so we see assigning these attributes or characteristics to babies as potentially a wonderful display of this concepts that emotion needs to be prioritized. And relational autonomy kind of allows for the balance of the head and the heart. And so when we see even something as simple as what is the baby's name? Is it a boy or a girl? That can be maybe just injecting some normalcy into the consult. It may establish that there is kind of a relational interaction that we need to think about here. And we acknowledge that. It may actually be a precursor to personal agency, that I'm going to kind of move beyond this concept of thinking about the baby on the monitor or on the ultrasound. And we're going to talk about how you think about your baby within your family. The future orientation of the child, so discussion within the consults about what the baby's life looks like long beyond discharge, right? Concepts that we want him running around and terrorizing his brother, right? As a mom kind of sits there worried that she's going to deliver at 22 weeks gestation. Or I hope he's not too much trouble in the future, right? And so that can be very loving relationship building. We also think about what does that instill as far as the decision-making process, intentionally or unintentionally. Ascribing characteristics, so kind of casting strength and vitality of the baby. Again, that may suggest decision-making towards resuscitation. She's strong. He or she is the boss here. He's a fighter like his dad. He's got the highest mountain to climb. Right? Those are attributes that we're ascribing to the fetus at this point, and eventually the baby in the NICU. The role in decision-making, that we join the parents, and that the baby joins us all in decision-making. We kind of let the baby declare itself. That's your baby telling us just the lungs are too mature. Make decision to listen to your baby. It's not even you making the choice, it's your baby. Because babies tell us my body's not ready. That kind of transfers the responsibility to the baby. Maybe it would say that you're kind of eschewing the shared decision making and saying we're going to transfer this to the baby and let him and her tell us over time. And what may be relational autonomy for the family, which is so important to acknowledge that emotional bond with their baby and have that kind of messaging for physicians, it may be very different in our use of this. And then different sub-things we saw within the physiology of personal agency as kind of a vehicle for accessible information delivery. We just kind of personalize this as a way to deliver information. The baby won't be strong enough to do it on their own. The baby doesn't realize they need to make the transition. They don't know how to feed on their own. Or the baby as the responder, we'll watch and see how he's responding. If he doesn't respond, it's just too early for him. We'll see how he responds, how he's growing, how his activity is. Or the recipient of the baby is the recipient of help. We'll help them breathe, stay warm, support their blood pressure. Or the baby as the actor, as basically kind of taking this physiology on, and they're in control. Baby's job is to grow the placenta. He's pumping blood through the umbilical cord. He's still got room to wiggle in there. Your baby's growing, he's becoming more mature. They can kind of fix themselves. And so at first I would read this and I wouldn't think anything about it. I talk like this all the time with families. But we kind of think about what effects does it have and how they think this personal agency works versus how physicians are using it. And again, I'm not describing that this should or should not be done. It's just the really rich interplay that happens. This is probably the biggest example that we saw. So my hope is that we can somehow reframe that question and know that your child is going to make the decision. He or she is the boss here. Yeah, that's for sure. We are kind of his or her soldiers, and we're looking to we're all aligned and listening to your baby. And to feel responsible of that decision because he or she is guiding it. Right? So there's really a lot of transferring of decision making to the baby. So I want to play to further kind of illustrate this concept of personal agency. I just wanted to make sure I had enough time. But I want to go back to Kelly, French, and Tom and their experience in the NICU. Because I think it's really rich, and I think it really captures this personal agency that we tend to assign.
Now, when a baby is this early, the parents and the doctors are watching it very carefully, trying to guess, is this baby ready to be out in the world? Is it going to make it? And Tom says when she grabbed his finger, that wasn't just them bonding. He felt like she was saying something to him.
She made her will very, very clear.
The baby declared itself, like declared its will to live.
And that was a phrase we heard again and again.
Some babies will, if I can use the term, declare themselves over the first few hours and days of their life.
That's a neonatologist we spoke to, Keith Barrington.
You get a gut feeling
And that's Diane Lizelle again, the nurse practitioner.
after meeting the baby that this one looks very fragile or this one can do it.
The baby has declared itself. Now, there's a real question as to, what does that mean? What are you seeing when something that premature declares itself? And here we ran into a real difference. Parents will often see will.
An incredible will and resolve.
Doctors and nurses.
No,
Not so much.
That sounds a bit too mystical for me.
I wouldn't take it as there's a voice inside the baby saying, I'm going to be a fighter, I'm not. One is sick enough not to be able to fight, and one isn't.
Can you see a spirit in a kid?
I think you can see some fight.
I call it spunk a lot of times.
That is Tracy Hullett.
I'm a registered nurse
She was Kelly and Tom's primary nurse.
at All Children's Hospital.
And like everyone we spoke to on the hospital side, when it comes to this issue, she chooses her words very carefully.
I maybe try to keep things a little bit more neutral than talking about their will to live.
Because, a baby at 23 weeks barely has folds on the outside of its brain. Its brain is still smooth, for the most part. So who knows what it's capable of thinking or feeling?
Well, that's a difficult question.
And the truth is, things like
Fight.
Spunk.
may just boil down to physiology.
Maybe that baby had a few more lung buds to start with.
Maybe it had an easier time in utero. May have nothing to do with will. In fact,
The baby grasping the finger of a parent, it's actually a reflex. That the babies have a grasp reflex. I never tell a parent that because they think it's an intentional movement.
Because, putting yourself in the parent's head, if you've got to decide how much am I going to push, how much of my heart am I going to pour into this little creature? Maybe if you can see something like will or something like intention, if you see, oh, that's a person in there, or maybe if you don't see it, maybe it's the only way you've got to make this decision.
As my wife, the professional ethicist, often says, we don't make important decisions in our life for rational reasons very often.
Keith and his wife, Annie Janvier, have done a huge amount of research into the ethics of extremely premature births. But one of the primary reasons we wanted to talk to him is that, in addition to being a neonatologist and a guy who publishes a lot of stuff in this area, he and his wife recently had a baby girl who was born at 24 weeks and 5 days.
She weighed 720 grams.
1.5 pounds.
And she was actually in my own NICU.
Oh, wow.
I was actually the director of the unit where she was.
So he was in his unit, the place where he usually worked. He saw babies make it, not make it, and now suddenly he was a parent in that place. And several weeks after his baby was born, there was a very, very big complication.
She actually didn't move at all for about 36 hours. And we thought maybe it was a little...
Maybe it was time.
Yeah.
So they decided, he and his wife, to let her go. Peacefully.
But I went back into the NICU to see her.
And something happened. He looked down, and he saw her lips move. Barely.
She started sucking on a soother that the nurse had put in her mouth.
She was sucking on a pacifier, and it was just a reflex. The most basic baby reflex, the sucking reflex. He knew that.
But just that movement of sucking on the soother
changed his mind completely.
I went back to Annie and said, we can't stop. I really need to continue and give her the chance.
But you knew that the sucking response is not, that's a fairly deep brain.
Yes, it's a very basic, it's just the brain stem. It's not, and you need a lot more than be able to suck to do well. But as I say, I was trying to be the parent there, not the neonatologist.
Well, could you remember if the doctor in you was surprised at the father in you?
Yeah, I think I was actually a little. Yeah.
I think it's a great example of even the neonatologist that, as the father, kind of saw that sign, that personal agency as a reflection of relational autonomy in a way. And it illustrates, I think, personal agency perfectly. So implications for practice, and this is quite premature, no pun intended, but antenatal consultation at the limits of viability navigates pervasive uncertainty often by extolling large amounts of statistical data or experiential storytelling that may potentiate actually further uncertainty. Personal agency is commonly assigned to the fetus in order to connect relational autonomy, provide accessible information, or really potentially even eschew decision-making responsibilities. And the antenatal consult may not facilitate informed decision-making. And this is something that I've just felt for years, going in at 2 o'clock in the morning thinking that we're actually going to reach a truly informed decision and being like, well, it's a family's choice. It was informed. I gave them all of the information. It's just a myth. But rather, it really marks an essential entry point into what can be and oftentimes will be this trusted physician-parent relationship necessary to reach a shared decision regarding resuscitation of the periviable neonate. And I guess I'll finish with a picture of Kelly French and Tom and her daughter Juniper, who I met and is as healthy as she looks in that picture. And so I would invite you to read her story, and she really captured it in a way that any physician giving a talk never can. And with a few remaining moments, I'm happy to take any questions, and then I'm sticking around for about an hour afterwards, and happy to talk then too. Done.
I'm going to ask you to speak into the mic so everyone can hear.
Great study, really needed, and there's a lot of information here. The personal agency stuff is really fascinating. I totally concur with you and see it all the time, and I wonder what it really means. But did you do any look at the amount of parental engagement? In other words, how much did they talk, ask, were they engaged, and how that varied with physician characteristics or the characteristics of the conversation? I've had a hypothesis that if you make a real effort to engage the family very early on in a discussion like this and get them talking, that it increases then their later engagement, not only in this conversation, but in the decision-making process all the way along.
Yeah, so that's a great question, and one that I've gotten a couple times when I've presented this, and probably something that is necessary to go back and show more quantitative data around, because a lot of conversation analysis will demonstrate exactly the proportion of physician speak versus parent speak. And we talked about that early on, but really, and I relied on our sociologists, which I still agree with, that it just doesn't capture the richness of these types of themes. That being said, to your point, if we start making bigger conclusions about how we can do this better, or how this work can inform better pathways to communicate with families, I do think that type of analysis is important specifically to that point. If we see consults in which there's larger swaths of parent engagement, and just quite frankly, there's very little in these consults. But then what happened within those consults specifically? And I think we may need bigger numbers to make big conclusions like that versus kind of the thematic saturation analysis with 25 consults. But it's a point well taken. I think to some degree we're going to have to capture that a little bit better. Yeah.
I think that leads into my question, which was how you would use what you've learned already from your data to improve the teaching for yourself or your fellows on how to do these challenging consults that we have to do too frequently.
Yeah. I was actually, I think uncomfortable for all the neonatologists in our group knowing that I was looking at these, but actually it was incredibly valuable because I was able to see devices that they use that I found very, very effective. And the researchers were really like, we have to have your group read all of these because some people do this particular thing incredibly well, and some people do this very well. And so as you think about formulating how to teach this, I think the biggest thing that I come away with, and the one thing that I would try to impart to anyone having these consults, is we don't need to check all the boxes with the information delivery. We can really engage in what is necessary for that particular family and spend a lot of time exploring those needs. And it may be just kind of